Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. So I hope everyone is having a good December. I know I'm done Christmas shopping. I've been done for about a week and a half. I get a head start. I start in August. I even wrap every single stocking stuffer. I'm kind of crazy that way, but it's fun. I love it. And since I don't get to see my daughter until after the Christmas holiday, when they become an adult and get married, you got to share them, which kind of sucks. But I'm excited for when they finally do come and see us. We have a lot planned. So I hope you have a lot planned for whatever your holiday is, whether it be Christmas or Hanukkah or Kwanzaa or whatever you celebrate. I hope it's getting exciting for you. Okay, so today I actually wanted to talk about and clarify something that I'm seeing in my end of the year audits. And boy, we've had a flood of them. So I'm really happy to see that everyone is saying, you know what, we need to figure out if we're doing things correctly. Unfortunately, some offices are saying they're getting audits from major healthcare companies. I saw one practice that said, we need your help. We just got an audit request from UHC for 1,997 records. Had another practice saying, and from us, they want 2,900. I'm like, holy moly. Almost said another word, but I'm just like, that is crazy. So one of the things that's being questioned in some of these audits is the difference between the independent interpretation and the data point, which is actually a category 2 in the level 4 visit, or the review, or the review of the external note, or the results of a unique test in category 1, which is a low-level visit. So I can see why there's a question about it, because just that one thing could possibly boost the level of service up one, which is usually around $45. So we want to make sure that we are doing what's required as far as documentation, understanding, and I hate to say this, but the spirit of the code, but a lot of the payers now are saying you didn't use this code as it was intended. And a lot of the providers say to me all the time, well, where does it say that in writing? I'm sure anyone listening to the podcast gets that from their doctor or their administrator or their provider, or their, mid-level provider. Not everything is in writing. A lot of things are what they like to call common sense or inferred in the published guidance. And some things are not so much. So let's take a look at it and just see just to try to make some clarifications, just so you're not over coding something. I would hate to see you get in that situation where somebody said, send me 2,000 records. And remember, a lot of times the payers, they're not doing what I tend to do when somebody requests an audit from me, where we set up IT, we basically set up a VPN, so we have remote access to, obviously HIPAA protected, but remote access to your EMR, so you don't have to copy. But that's not what the payers do. The payers want you to actually copy white paper for them so that they can do an audit on you. And so that's very tough, and we would never do that to you. But just so you know, I just want this really clarified, because I think this is such an issue. And what I'm seeing even in my audits, and I'm giving recommendations to clients that come to me to audit them, is that this is being overutilized as far as independent interpretation of tests. But let's talk about that and make sure that you're doing it correctly. We just don't want you to get in trouble. The Codecast podcast is also brought to you today by Just Coding. This is your timeline, online continuing education destination. Pay one price and earn dozens of AAPC, ACDIS, and AHEMA credits annually. Save 10% off a new subscription using coupon code SAVE10. Visit justcoding.com to subscribe. It's always fun to have sponsors, isn't it? Well, it is for me anyway. I like having people saying, hey, we want to sponsor you and here's some money. I love that. I don't know about you guys, if anybody else is also podcasting, but it's always fun to have somebody else take up the expense of what it costs to podcast. Okay, so let's take a look at this. And it's interesting, and I'll thank my good friend Shannon DeConda of NAMAS, because she also wrote an article on it at namas.co, so NAMAS.co. And also, no, I have an article up there on the telehealth nonsense that's going on where oh my gosh, 90% of people could lose their telehealth coverage with Medicare by the end of the year. So take a look at that as well. But let's just kind of go back and look at the really understanding independent interpretation versus what actually would be considered a review of a result of a test. Unless if you ordered it, then you can't also charge for the review. But if you did not and you're just reading the paper, then you can charge for that. Or review of a prior external note from each unique source. So if you get hospital records, that's one source, it's not each record. So things like that. So let's take a look when we're looking at E&M services. And this is such a misunderstood concept, or I should say component, of the data points. So what are the 3 essential requirements, let's say, to ensure compliance and appropriate coding? Well, first of all, there's personal review of the test. And what does that mean? Well, if you go back to 95 guidelines, and remember, they've been retired, but they haven't been archived, meaning that they still exist. If you're doing any kind of, and I keep having to bring up telehealth, but telehealth in the hospital setting, the initial time, if you've never seen the patient, I don't know if you've read the Medicare Integrity Manual, but it says that they're still using 95 and 97 guidelines for the G codes. So there are times when you still have to refer back to what that means. And the term independent in an independent interpretation underscores the necessity for the provider to personally review. So it's an independent review. You have to personally review the diagnostic test. Now that could be an image. So if somebody brought you an MRI or an X-ray, or it could be a tracing. Somebody brought you a specific echo. Or a stress test, or it could be a specimen where you are actually looking at a specimen through a microscope. This means the provider must go beyond just reading their radiologist or pathologist report, and they need to examine the actual images, slides, or tracings themselves. That's why you get the extra money. So relying solely on another professional's report does not meet the criteria for independent interpretation. Personal review of that actual film would be performed when a provider needs their personal view to make the best informed decisions based on first-hand analysis, yours, which may reveal maybe some nuances or some things that were not captured in the initial written report. So a good example would be a primary care physician personally reviews a patient's chest x-ray images to assess subtle signs of pneumonia that were not highlighted in the radiologist report. Another one actually had happened to me where I'm dealing with frozen shoulder of the right. If you've ever had that, and women over 50, it sucks. And it just, oh my gosh, there's some nights I can't even lift my arm. And so it's just something you have to work out through physical therapy, whatever. So my primary care doctor took an x-ray and he says, well, I can see some arthritic changes, but I really don't see anything. I'm like, okay. Well, so I took it upon myself to go to an orthopedic surgeon, which was not cheap, by the way, and said, I'm going to bring my films in there as well. Had to sign those out. That was also a hassle because they're like, well, we can give you a report. I'm like, no, I actually want my orthopedic surgeon to take a look. And he did, and he said, actually, you've got a tear and you have a labrum tear as well. So those are things that, yes, that would be a personal review of the image and the test where that would be a bumped up data point. And the documentation of the second thing is the documentation of the provider's own interpretation. So after they personally review the test, the provider must document their own interpretation in the medical record. And this should be a clear, concise analysis that reflects the provider's findings from their review. Now, it does say in the documentation guidance, it doesn't have to be a formal interpretation like something that follows the film. But here's what we would recommend as far as best practices. It's just to make sure that if you're ever audited on this, I mean, if I'm your auditor, I can see this. This is what I'd want to see. First of all, findings, specific observations noted during the review. Your assessment. What's your professional judgment regarding these findings? And then your conclusion. How these findings influence your diagnosis or treatment plan for that patient today. And why does that matter? Because this is evidence that you performed an independent interpretation, which we need, again, not just for coding and billing, but we need that for if you're ever audited. And it looks and enhances really the continuity of care by providing detailed insights into that patient's condition. So when I talked about the chest x-ray that saw the evidence of a small infiltrate in the left lower lobe, or my own experience where my primary care doctor missed a tear in the labrum and also a small tear in the rotator cuff. It's just like, and it's not an incompetent thing. It's just now you've got a specialist what knows what to look for. That's like, hey, yeah, you have frozen shoulder, but you also have a problem here that needs to be cleaned up. And then number 3 is demonstration of impact on patient care based on the AMA's definition of analyzed. Remember, the data component says amount and or complexity of data to be reviewed and analyzed. That's what was added in the 2021 changes or updates to the E&M service. And the AMA really emphasized the importance of how any reviewed data is analyzed and how you have to reflect within your note that it impacts your clinical medical decision making. So for the data to be considered analyzed, not just read, the provider must demonstrate how it impacted this episode of care and how your independent interpretation, again, your upcoding, influenced the patient's episode of care. So in your documentation, what we recommend, clinical relevance, how did this finding affect the patient's condition or their complaint? Treatment decisions, detail any changes or confirmations in the treatment plan based on the interpretation. Patient outcomes, highlight potential implications for the patient health outcomes, especially if it's different than when they got the original test or by the person that ordered it. And again, I'm going to refer back to my situation. And simply reviewing and documenting findings, that's not enough to establish the medical necessity for reviewing a previously interpreted test. Because remember, the physician who actually did or ordered the test or performed the test and also interpret the test, they may also be billing globally, but they've billed for that interpretation. And the only way for you to really capture that is in your documentation, and you need to clearly demonstrate how the provider's independent review added value and impacted the patient's care, because now they're going to be technically charged again with the upcoding. And that just validates the necessity, the medical necessity of the independent interpretation, and now you've fulfilled your coding requirements. And we just have to be very careful with this, because encounters, let's say in the inpatient setting, have a lot of errors related to independent interpretation. I see it a lot in the ER too. Providers often have daily access to imaging and other diagnostic tests, and I see a lot of providers saying, well, my belief is that reviewing previously interpreted tests automatically adds value. But it's important to remember that just because you have availability of that test, that does not make it inherently medically necessary to perform a second formal review. Remember, this is considered an independent interpretation. Why does it have to be independently interpreted? You have to document how this additional review impacted the treatment or the patient's clinical course of that patient. So without justification, that second review, just because you can, doesn't make it medically necessary, and that can lead to upcoding. And that's why, especially in the inpatient setting, that involves complex and dynamic patient conditions where multiple tests a lot of times are frequently ordered. I know I had a friend last year that went in and they thought she had a stroke, and so they ordered a CT, they ordered an MRI, they ordered so many things, and then everyone thought that they could just, put in the independent interpretation, but the neurologist was the one that actually spoke to the patient and counseled them on what was going to happen, and so it wasn't really necessary with the other providers. And you don't want to deal with, unnecessary compliance concerns. You don't want to get in trouble for upcoding. The insurance companies are really looking at that right now. And you want to really educate your physician on the best practices for this kind of documentation. It's tough on the ER. I know. I see something on LinkedIn recently, and I disagreed with the doctor. I got a lot of flack for it, and because he was an educator and he was not being currently clinical. And he's like, every time you do an EKG, that's an independent interpretation. I'm like, no, it isn't. The hospital is doing the EKG. I said, you ordered it. You reviewed the strip. I go, you can't also include an independent interpretation because that's already being billed. It was a complete conversation that did not end well. Anyway, I stepped out of the conversation because they're not going to listen. Well, then a year later, guess who's knocking on my door, or I should say on my email, saying, hey, we got reviewed. I know we had a back and forth on LinkedIn. Is there any way you can help us with this? Because I think we're going to have to send money back. And I'm telling you, it was hard for me not to go, I told you. So I was like, sure, let me take a look at what you did. Luckily, half the records actually were compliant. Half I questioned, they were suspect, but half were not. But I mean, at least it was a big enough person to actually say, yeah, we probably should have listened and not went all out. It's kind of like the practices that are attaching that G2211 to everything. Remember, too much of a good thing is too much. You don't need the whole cheesecake. You don't need the whole chocolate cake. Just take a slice. It's okay once in a while that this is appropriate, even probably, I would say 20-30% of the time, because when your patient is sent over for an imaging study or path, or, I think of primary care doctors, or practices, or urgent care centers. Urgent cares are big on saying, we don't have an MRI machine. We don't have an x-ray machine here, so I'm going to send you quickly to the ER, which is never quick, but I'm going to send you over here to get this done, and then we recommend that you follow up with an orthopedic surgeon, okay? So, or we recommend you follow up with a general surgeon, whatever the cause is. Now, that practice is going to get, an external report, or I should say they're going to get the film, and they should request it if they're going to try and get the independent interpretation. If they just get the report, they're only going to get a review of a prior external note or a test result from outside the practice. But a lot of times when patients are sent to the ER to get imaging, just because the urgent care doesn't have it, they don't get the result there. They're like, okay, we'll let you know where to go. And the patient's like, well, I don't really have a specialist right now. And they're like, oh, here's one. This is one we use. So that's a different situation. But just be very, very mindful of this, because it is an upcode situation where it could come back to bite you. And I definitely don't want that to happen, because that can be such a problem, especially when you go from a low level 3 to a level 4 because of one element in data points. And I just don't want to see somebody say, well, no, that was just a review of a paper result. That wasn't an image. There wasn't a need for a re-review. There was, anything like that. So that's where that can definitely be an issue. Okay, so my personal tidbit for this week, my Steelers are 10-3. I'm so happy. And I'm actually recording this before we have our next Sunday game. So I'm hoping we're playing Philadelphia. So we call it an inner city game. So I hope we go to 11-3. I'm nervous, but I do hope we actually have to go to Philadelphia. It'll be raining. It'll be cold, but I'm excited for it. And then after that, we've got 3 games in 10 days. One on Saturday, one on Wednesday. It's crazy. We're just going to have a lot of, we're playing on Christmas Day as well. So, but it's been very fun to see all the winning. So I'm very excited about that. All right, everyone. I hope you're enjoying your holiday season, and, just get out and really enjoy it. Go get some hot chocolate and go look at Christmas lights or something. It's so fun to get out there and just see what everyone's doing. So, and drive around the block if you can. It's just something different to take your mind off work. So everyone, make it a great rest of your week. Make it a great day. And thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.